scoliosis, pediatric spine, and also talk a little bit about adult spine. But I also am going to be talking a little bit about, in general, what can you be doing as an OR nurse to help improve quality and improve safety. So even if you don't do scoliosis surgery in your OR on a regular basis, there are some things that we've learned, and I've learned from my OR nurses and other staff, that I think are going to be relevant for you. So, as you heard from the introduction, I kind of got into orthopedics and surgery sort of directly by accident, literally by accident. And when I was 16 years old, pediatric patient, I got hit by a car and ended up having a very bad leg injury. And it could have actually taken my life, but I was blessed that God spared my life and got me to a local hospital where this Dr. Pittman actually took on my case. Even though the first surgeon wanted to do an amputation, he had taken care of some very complex patients in Israel and was willing to take on my tough case. And so I was in the hospital, as you heard, about 3.5 months, had 11 surgeries. And I don't remember any of my operating room nurses, but I do definitely remember the nurses on the floor, and I also remember the recovery room. And one of the things that I remember still to this day, and that was a long, long time ago, over 30 years ago, I still remember to this day a recovery room nurse putting on a warm blanket. And, you know, I think that as we get started this morning, you're hearing your lectures and so on, I think that all of us went into medicine for various reasons. But for all of you, I think it's not just for a paycheck or because you enjoy using Epic, but because there was this thing that drove you, maybe even as a little girl or a little boy, that you wanted to care for people. But I can tell you that even despite Epic, you know, just remembering that warm blanket for a patient, or that comforting word for a patient or family member before they go back to surgery, changes lives. And I still to this day remember that, and that's one of the reasons why I wanted to become a physician in some way to help. This is just a picture of the physical therapist actually who took care of me, Barbara Bader, who also was key in my healing, and not just physically but emotionally, teaching me how to walk and helping with wound care. So it's definitely been a team effort to get me better, and whenever I view taking care of patients now, including the complex pediatric patient, I fully realize that the role that you play is just as important as mine, and we have to work together. And that's one of the things we're going to talk about today. So how did I get interested in getting into spine? Well, first of all, I had this external fixator on my leg and had a big gap, as you can see, about a 2 or 3 inch gap there where it was just lost. And this frame that was on my leg was not quite strong enough to hold my leg in place. And so I was a tinkering kind of kid, and built motorcycles or fixed motorcycles and liked building go-karts. And so my dad's an engineer, and so I was kind of a tinkering kind of guy. So I actually redesigned this frame as a teenager to make it stronger using triangles. And my doctor kind of laughed when he was willing to put this new frame on. And that was one of the things that helped me to have less pain, but also helped the bone to heal. And so I was thinking, goodness, maybe God could use this tinkering ability combined with being a patient to help other patients in the future, which is why I went to engineering school and then to medical school. After I finished medical school, I was working with this guy here, John Hall, at Boston Children's. And Dr. Hall is one of really the founding fathers of modern scoliosis surgery. He was actually in his 70s when I worked for him as a resident and as a fellow, as chief resident. And so Dr. Hall wasn't putting on external fixators, but he was putting in internal fixators inside and literally transforming lives, taking these crooked little kids and giving them really a whole new life and a whole new posture. And it really appealed to that engineering side of my brain and the difference that I could make. And so even as a junior resident, I got this idea of like lifelong scoliosis care and how we could use engineering to help patients across that age continuum. And so I did pediatric training at Boston Children's in scoliosis, and then came to North Carolina over 20 years ago and did a Duke Neurosurgery Orthopedic Spine Fellowship, at which point I joined the orthopedic faculty at Duke. I was there for 10 years. During that time, learned a lot and served a lot, taught a lot of residents and fellows, and then 10 years ago, a little over 10 years ago, moved my practice to Raleigh and set up the Hay Clinic, where I've been since then. And I work primarily out of Duke Raleigh Hospital, but also here at WakeMed. I do my younger pediatric patients here at WakeMed and the kids with special needs, and I do most of the healthier adolescents as well as my adult patients over at Duke Raleigh. So one of the things that I learned a lot during my first few years in practice was I had several mentors. Dr. Hall was one of my mentors, Dr. Pittman was a mentor, but another key mentor is this guy right here, whose name is Satya Sharma. And Satya is one of the Deming Award winners. And Deming, as you may know from quality, was the guy who really is the godfather of quality. And in the 1950s, Deming is the guy who worked with Toyota after World War II to basically revolutionize modern manufacturing with quality, TQM or total quality management. And that now is affecting pretty much every industry, including hopefully some healthcare. But Satya was my mentor for process improvement. I had developed some information technology solutions that were being used by Duke to get doctors to use computers directly and to use that to improve quality, improve outcome assessment, and be able to actually integrate clinical research with care. And so I worked with Satya, and Satya suggested this book called The Machine That Changed the World. And in there it tells the history of how actual total quality improvement came into being with Toyota. And the key thing here is that what Toyota did with Deming's help is they looked at the process of building a car, starting from the raw materials on one end and going all the way through the finished product. And what they did that was unique was they started from ground zero, because Japan was destroyed, obviously, after World War II. So they literally started this Toyota plant, and they decided they were going to build their plant based on total quality management. And Deming was helping them to do that. What they said was, we are going to prevent mistakes before they happen. And whenever a mistake happens, or an error, they're going to stop the assembly line and actually talk to the guy, let's say the guy who's putting on the fender, and say, now why didn't this fender go on right? And so rather than having it being solved somewhere else, they actually talk to the fender guy, because who knows more about putting on fenders than the fender guy, right? Some guy out in, some hired consultant doesn't know about putting on fenders. You should talk to the guy or the gal who's been putting on fenders for the last 20 years and say, well, why did this fender not fit? Well, actually, it's because when we get it from the shop, they drop it a lot, it dents it, and it doesn't fit. And so they go through the root cause analysis, and working with the fender guy, they figure out the best way to prevent that mistake from happening again. And so when they started this plant, they would not, as soon as that error happened, they actually stopped production, figured that out, and then improved it, and then they actually went on and let the assembly line run again, which was totally different than the US model. In the US model, if there was a mistake, nobody on the assembly line had the right to stop the assembly line. What did they do? They just let it go on, right? And at the very end, they had this area called the rework area, right? Where if there was a dent in the fender, they'd have a guy there buffing it out, or the carpet was torn, right? But that's not a great way to build cars, is it? Because the American car back then, guess how much of the factory space was put aside just for the rework? 28%. 28% was focusing on fixing stuff that was not done right to begin with. Now, does any of this resonate with you yet? How many of you had to deal with rework in your job? Okay? The doctor forgets to sign the consent form, or the equipment doesn't show up, right? And you're just like, everything just did it, and I get yelled at, right? Does anybody agree with me about this, or is this not working? I just want to make sure, because I've been in the OR for a few hours. So the worker is actually empowered in this case to speak up and say, let's fix this so we don't have to deal with it the next time. So when they did this for Toyota, do you think they made a lot of cars in their first month? No. Why? Because they were working on the problem. That's right. They were perfecting the process, right? But guess what? Then the next month, they made some more cars. And then the next month, they made some more cars. And the next month, and the next thing you know, here we are in 2015. And how many of you drive a Toyota? Okay? All right. And how many of you are driving a car that was affected by Toyota's total quality management? Raise your plant is now out of business, okay? That is the way you get a great Toyota Prius or a great Lexus or a Honda. Every single car on the planet right now is built using that method. Now, let me ask you a question. We talked about the rework that was done in the Ford plant back then. And U.S. companies, by the way, have also adopted this, which is why they're still in business. So what percentage of the Toyota plant, once they got it up and running, was then needed for rework? So we said 28% before, right? So once they put in this TQM process, what percentage of their floor space was actually used for rework? 0! Right? Because they fixed it by design, okay? How much of your day is actually still invested in rework? How many of this is 0? Raise your hand. Oh! So we have some room for improvement, don't we? But if you really think about like the OR process, right? You think about it like there's where I start off, and Dr. Edwards starts off in the clinic, right? It all starts off with us, where Dr. Edwards decides, I'm going to fix the left thumb, right? And he writes out left thumb in his chart, and he books it with his surgery. So he's starting that whole process, right? But then it goes through OR booking, right? And then where does it go next? It goes to the pre-op area, you see? It's just like an assembly line. It is. It's just, instead of building Toyotas, we're dealing with people. Okay, now just for a quick gut check, which one's more important? A Toyota Prius or a human being? Human being, right. And so, is it important for us to do quality management where you guys are? It's actually just as important, if not more important. Okay? So this is something that I became quite passionate about, because it also, it's like it's called industrial engineering, and Satya was really a huge change. So it totally changed the way that I thought. And that's what we need with quality management. It's like a mindset. Your mindset is, I can always be better. We can always work better. We can always eliminate other errors. And it's just like, it's this passion that you have to have that you're never satisfied with where you're at, okay? And so that's kind of the way that I've been running my practice, but also working with my OR staff. So with that, there's 3 big lessons that I've learned in life that has to do with this. The first one is compassion. Life is precious. That should be the motivator for us to keep making things better. Not just for our patients, but for each other. So I should be compassionate, not just about my patient, but about my staff. Staff do not like to get yelled at, right? That's not a way to get the best performance, out of your staff. And so we need to treat each other correctly, as well as treat our patients one. The second one is humility. And actually, all of these 3 things, compassion, humility, and learning, I just met with a brand new spine surgeon who just started at Duke Raleigh. I mean, literally, he hadn't even done his first case yet. And I was thinking, I've been blessed with good mentors, right? So it's important for me to pass it on. So I just offered to sit down with him. And he's a great guy. He'll do great. And so I shared with him, I said, you got to remember 3 words. And the 3 words are compassion, humility, and learning, or error prevention. And he actually wrote them down, and so now I'm sharing them with you. So humility is the next one. Surgeons sometimes have an issue with that. I don't know if that's true. but I think humility is one of those things where it's basically you realize that you're really not any better than anybody else, right? I've got my role to play, Julie's got her role to play, and we all have to work together. And as a surgeon, you're sort of the captain of the ship, and so you have to be the catalyst and the one who's ultimately in charge. But you really need to keep a humble attitude to listen and to improve. And then the last thing here is the whole error, learn, improve approach, the quality approach. So I want you to write this down in your little book there. I want you to write down ELI. E-L-I, okay? ELI. So quality improvement is as simple as the word Eli, or the name Eli. And that's what we call it at Hay Clinic. And one of my former PAs, her boyfriend and now husband is named Eli, and so we came up with this term because it would be easy for her to remember. So E stands for error, and what that means is be aware of when errors occur. And instead of trying to sweep it under the rug, or hide it, or ignore it, what you do is you grab a hold of it, and you say, wow, we just made an error. Maybe it was a dissatisfied patient. Maybe it was a piece of equipment that didn't show up. And you grab hold of that, because an error Identifying an error is a chance to learn. Okay? So then you say, well, why did that error occur, and what can we learn from that? Well, just like the fender guy, you can learn from why that thing's happened. There's all sorts of errors that can happen. And then what we want to do is I, which is improve. Well, how do we prevent that from happening again? So you can do this for every little problem that comes up in the OR. And so in our staff for Hay Clinic, we have a weekly quality improvement meeting, because we deal with the process, as Dr. Edwards does, on the whole outpatient side as well as inpatient. And we practice this every week. Every single Hay Clinic employee or associate has a responsibility to report ELIs every week. And we discuss them as a staff. And if you wanted to come and share that with your hand clinic and how we do that, it'll change the way your clinic runs. Because then every employee, every associate is empowered, right, to be part of the quality improvement process. So in my office, just like, I'm not building Toyotas, right? We're not putting on fenders. I have people that are in billing, okay? So if I have somebody in billing, and we have a problem in billing, who is the best person to fix the billing problem? Is it Dr. Hay? Is it an outside consultant? Or is it Jennifer in billing? So we should listen to Jennifer, and when she has an error or a problem, we should listen to her, and the chances are the problem is probably not just with Jennifer, right? It may be with me. It may be that I forgot to document something, which then made the pre-cert bounce, which then made her job want to pull her hair out. You see what I'm saying? So we talk about that in a circle, and then we all agree that we learned this from it, and now we're going to move things forward and improve things. Now, maybe changing something in our information system. We have our own custom information system. It might be in how we handle that particular type of payer, or whatever. Okay, so the whole important thing is, it is so good as an employee to feel like you are empowered to make things better. Do I hear amen? Mm-hmm. I mean, even if I worked in Zambia for 3.5 months in a mission hospital, okay, it was not a great hospital, okay? And certainly compared to our hospitals here in the States. But it worked. And every week, every month, we were doing things to improve that mission hospital, right? So as long as you're in a place where things are improving and getting better, and you feel like you're empowered to help, it makes it better to come to work, okay? So Eli, remember your ELIs, and then have that Eli mindset. Let's talk about the role of the OR nurse. I did a calculation this past week, actually, so one of my staff did, and I was trying to just celebrate my 20th year in practice this year. And so I've been thinking about, like, how much time have I actually spent with you guys in the operating room? And so first of all, I definitely spent a lot of time with nurses, because from age 0 to 18, my mom took care of me, and she's a nurse. So all those hours should count, right? And then on through my training years, which were thousands of hours working with OR nurses and other nurses. Now with my 20 years in practice, I had my computer programmer calculate this out for me. 20 years in practice, 3 or 4 days per week in the OR from 7 a.m. to 5 p.m. or later, and average surgical time 4.2 hours. And as of today, 6,272 surgeries, 3,989 of those were scoliosis or other spinal deformities. So if you do the math on that, we don't have actual hours for all of them, but for the last 10 years I do. But he was estimating about 26,000 hours of OR time. I kind of downgraded that to be more conservative to just a mere 22,000 hours that I've spent with OR nurses in the OR. That translates to 2.5 years of time that I have spent 24/7 with you guys, okay? So that's a lot of time. And so if you're miserable, that's a lot of time to be miserable. But if you feel like you're constantly improving and you're helping patients, I don't mind spending that much time, and it's been a blessing to do that. Now, I'm going to tell you a quick story about how quality improvement, how nurses actually helped me to improve quality. So it's 2005. I chose to move my practice from Big Duke in the academic center and actually start my own scoliosis center, in large part to do a better job controlling the quality. Because when you actually have your own center, as you'll learn from the Raleigh Hand Center, you have a lot more control over the quality than you do when you work in a large organization which has 50,000 employees. Okay? So So I made that change and built our own information system. So I started operating over at Duke Raleigh. And so after I was there for a while, people could tell that I was very interested in quality improvement, but they also know I was doing these crazy big cases. And so I was there for about a month. And the next thing you know, my OR nurse, Nurse Kelly, taps me on the shoulder and says, "We have to have a meeting." And I was like, uh-oh. So Nurse Kelly and Scrub Sandra and Scrub Sheila meet with me in the Duke Raleigh cafeteria. I'm like, what is this? I'm getting calls on the carpet. So they sit me down and they're like, "Dr. Hey, we really like working with you, but your surgeries are wicked complicated. And what you need, Dr. Hay, is you need a team. And you need the regular team. We got to figure this out, and that's what we're going to do. So what we're going to do is we're going to go to OR administration," and I was operating 4 days a week. And they said, "We're going to match up our schedules to actually match up with yours, and we're going to be your team, at least for the next year or so, to figure this out." And that was an awesome idea, because what they did was they were able to perfect the trays, right? They were able to perfect the setup. They were able to perfect the timeout, all of those things, because you had the same group of people working together. But then what they did is they could then be the trainers, right, for the other people. So people just didn't waltz into Dr. Hay's room. You had to go through the training from these 4 black belts, right, that had been doing it a long time. And so I still thank Nurse Kelly and the rest of them for doing that. And it really has set the standard, which was a lot different than when I was working in the big academic center. I loved it, it was fun, but you're getting different people every day, right? And so from your perspective, that's frustrating too, because you're getting thrown into the lines, and the surgeon starts screaming, right? Because you've never done it, and where's that XT wrench that you've never even heard of, right? And then the rep is pulling his hair out. Does this sound familiar? But anyway, so the way you do that is by having, teams of people, but then use that same team to do the training, okay? So what have we learned since then? Well, we've learned several things. The first thing that we learned is that compassion really matters. So one of the things that we've changed, and I do suggest doing this, if you're not doing this already, is it's really helpful for the circulating nurse to call the family, especially for these longer surgeries. So you can suggest it to your surgeon, but I really, for a hand case, it doesn't really matter because they're in and out in 4.2 minutes. But if you're doing I'll tell you one thing that happened where I saw this. This is about 8 years ago. I came out from one of my scoliosis surgeries, it was about 8 hours, and I met a family that was in the ICU waiting room. And they said, "Excuse me, sir, but could you help me? Our father has been in surgery for 10 hours with brain surgery, and we haven't heard anything all day." Now, how would you feel if that was your dad who's having something like brain surgery or spine surgery? Okay? So what we've always done is for the pediatric patients, we call out usually about every hour and a half, right, Julie? And for the adult patients, we make it every 2 hours. And all it takes is the circulating nurse just calls the family directly on their cell phone and says, "Hello, Mrs. Jones. This is Julie, or this is Nurse Kelly from OR 12. I just want to let you know that your son Jason's doing fine. Everything's going fine. I'll call you back in an hour and a half." Hour and a half later, boom, that phone rings. How does that mom feel? Mom feels good, all right? So actually, Wendy in the back, she works for me now. Her son had surgery with me. And it does. It makes an amazing difference. Somebody cares, and so on. And how much time does that take, okay? So if you had a choice of putting 3 more pieces of information in Epic, or actually calling a family and expressing compassion to them, I mean, we do have to put the information in Epic. I'm not saying don't do that. We're going to get in trouble. But seriously, we got to remember those things that actually make it feel like you're being a compassionate nurse. The other things that we've learned is, getting standard equipment setups. And one of the things that we've done is actually photographed our layout. So like I do a lot of my surgeries over at Duke Raleigh. I do less here, and so as Julie knows, we photographed all of the table setups. And so when we go to a new team, if you're the scrub nurse, right, you can look at the picture on the wall and lay it out that way, and that way the whole team knows where to find the tools, and it makes it a lot easier. Very simple. And then the evolution of the timeout. Timeout typically is just what? Patient name, date of birth, and the consent form. What we've done is gradually evolve that. I'm going to talk about that on the next slide. Preparing for intraoperative emergencies, vascular emergencies, as well as neurologic. For vascular emergencies, for doing anteriors, it's always helpful to have like a separate little tray, a little cart, And Nurse Kelly came up with this, where you have your like 6-O-proline and stuff. Because how many of you have ever seen like something like that happens, and they see the circulating nurse blasting down the hall, right? Looking for that 6-O whatever, right? Well, what if, you know, it only happens like 1% of the time. But what if you just had the 6-O-proline and all of that stuff on a little tray, so that if the vascular surgeon says, oops, we got a problem, all that she has to do is, instead of running down the hall with a heart rate of 180, she can just reach over and say, here you go. And neurologic emergencies we're going to talk about, and then infection prevention. Infection prevention for scoliosis and spine surgery is very important because we're putting in a lot of implants, just like it is for total joint. So we really have drilled down on things like room traffic, laminar flow rooms, moon suits, really being careful about our preps, using special tissue care, closure techniques so that we can decrease that. Because as you know, now hospitals are going to be, not only is it better for the patient, right? Because an infection is a horrible complication. I had an infection in my leg and it took months to get over. But, so it's the right thing to do for the patient. But now, with the changes with insurance, you know what's happening with infections? If you get an infection, basically what Medicare or the payers are saying is, guess what? You just did that surgery for free. That's great, okay? So that really is going to put hospitals in a bind because they really want process control. They want infection rates to go down to 0. Now, can it ever be 0? No. Probably not. But we can get it a lot closer to that, all right? So taking your time out to the next level. So whether you do spine surgery or you do something else, take a close look at this list and really think about how you can use this to help expand your time out. And once again, this is an area that I didn't take leadership for. I mean, I really wanted, you know, folks like Nurse Kelly to be here to give this part because she's the one who really deserves the credit. So we all have to do the basics, patient name, consent form, and so on. But the other things that are helpful to do are to confirm where the patient's symptoms were. So for like a lumbar disc herniation, if you do go out and see the patient in pre-op, right, you can ask the patient, well, which leg hurts, all right? So if they say their right leg hurts, and then you go in, you're going to do a left discectomy, is that a problem? Right. So correlating with the patient's symptoms is very important. But the other thing we have to do is make sure we get the right level and size. So I'm going to tell you a quick little story that might change the way you work in your OR, and maybe you can even get in the face of your surgeon and suggest this. So I'm driving home from work one day, and I'm listening to National Public Radio, and I'm listening to a case of a surgeon who is a kidney cancer surgeon. And because the fact he's on NPR, that's not a good sign, right? And so they're talking about this kidney surgeon, and basically he does exactly what Dr. Edwards and I do in clinic. He sees the patient, he makes the diagnosis of kidney cancer, and he actually gets the patient to fill out a consent form, and he documents in his clinic note that he's got left kidney cancer, and he's going to do a left nephrectomy, which makes sense, right? And he sends that into his staff, which goes to the operating room, and they put it into the operating schedule as a left nephrectomy. Sounds good, right? So then we get to the OR, and the nurse does her timeout, right? So the nurse says, this is patient Jones, blah, 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 and we're going to do a left nephrectomy. All those in favor say aye. Aye. Okay? So then the surgeon comes in, says, that's the left side, I'm taking out the left kidney, and takes out the left kidney. Well, they get the kidney out, and they say to the pathologist calls the room, ding, ding, hello, there's no cancer. Okay, now who in the room, thinking about process, can figure out when the error happened? When? Raise your hand. When they turn the patient, okay? So maybe they turned them, and they actually put the right side up. That's possible. That would be pretty bad. So we should know the patient's left from right, and that's not the right answer. When did the error actually happen? In the diagnosis. So when Dr. George or I are in the clinic, right? George is busy. He's seeing, 60 patients a day. He's a very famous kidney surgeon, right? And so he put the image up, right? And it was the right kidney, but he dictated left, right? And as soon as that happened, that error went all the way down, right, until you're there as the OR nurse answering the phone from the pathologist. How are you feeling now? Very bad. So what do? Flip the patient over and take the other kidney out? That is a big problem. So I'm driving along, listening to this, saying, I feel bad for this surgeon, right? How could the OR nurse or the OR team have actually stopped that error from happening, or the surgeon in the OR? Is that? Ask the patient. The patient says it's his left kidney. Why does the patient say it's his left kidney? Because Dr. Edwards told him so. Imaging is absolutely right. So as I'm driving down the highway, we have our own electronic health record where we have all the imaging in there already. Okay? So I said, I'm going to change my timeout tomorrow and include what in the timeout? And what we do is we actually have the image. In this case, you have the images of the two kidneys up there on there. And on the image, it says left and right. And so let's say it's Dr. Edwards. Dr. Edwards would come up and say, we're going to do a left nephrectomy, and I'm looking at this image, and it's, whoa, the tumor's on the right. Okay? And he'd say, stop. Stop, right? So we do, I don't take out kidneys, but I do discectomies, right? And actually Dr. Edwards does hand surgery left and right, so side's important. But I've got another issue that the kidney doctor doesn't have, is we have multiple levels. So whenever I do a timeout, I'll confirm that the disc herniation is on the left. The patient says his pain is on the left. And we said, and the disc herniation is at the L4-5 level, and we are going to do an L4 laminectomy and L, see what I'm saying? So just look at the picture. So if you're doing a cancer surgery and it's side to side, or if you're doing a spine surgery, if you're the OR circulating nurse, I would suggest to your surgeon that you include him or her, even if they have to pull it up on packs. Is it worth taking an extra 30 seconds to pull it up, as opposed to taking out the wrong level or the wrong side? So anyway, that's a little pearl that ended up changing the way we do our timeout. Okay? And that's relevant for spine surgery, whatever you want. Evoked potential monitoring, initial reading. We check that our initial, just ask the evoked potential person as we get started, are your evoked potential, how are your signals? If they're not normal at the beginning, they're not going to be normal at the end. And giving adequate time for prep prior to draping. We actually have timers for that now. And then team members establish the safety zone so you don't get cut. There was a surgeon over at Duke recently who actually had his ulnar nerve cut because he leaned down on a knife blade, and now he can't use his hand anymore. So the safety zone thing is not just safety for the patient and for the OR nurse, but even for the surgeon. And then what we do is we say, does any other team member have a concern? So make a note of those, that list of timeouts, and just think of your timeout as a way of really getting your quality nailed down. The next thing we're going to talk about is that also you should make a note of how many of you actually are involved with any sort of spine surgery at your hospital. Raise your hand high. Okay, good. And how many of you do they do like spinal cord or evoked potential monitoring? They do that as well? Okay, so for all of you that are doing that, or even if you think you might need to do evoked potential monitoring, you need to take out your pencil, and actually I think, Wendy, you gave them a copy of this, right?
I did.
You guys should definitely share this article with your spine surgeon, okay? The Scoliosis Research Society that I'm a member of spent a lot of time and energy coming up with this very good intraoperative checklist for what to do when the spinal cord monitoring changes, okay? Because whenever the spinal cord monitoring changes, it doesn't happen very often, it tends to create panic, okay? Now, panic is a very, very bad thing. Whether you're a pilot, my dad's a flight instructor, he trained me very early on, don't panic. Because when you panic as a pilot, what do? You crash, okay? So you can't panic. You can't let your emotions get ahead of you. And surgeons can panic too. And so this could help your surgeon, Dr. So-and-so, let's just do the checklist, okay? So you're calm, and we're just going to do the checklist. And what's nice about that checklist, as you can see, is it just breaks down in different categories. So you can literally just take that one page, flip to this page on your checklist, in your handout for that. And basically what it shows is it tells you to gain control of the room, turn off the music and all that. That's what you'll do as the nurse. You announce there's going to be an intraoperative pause. You summon the anesthesiologist, the neurophysiology neurologist, and then anticipate the need for imaging. So it tells you as the circulating nurse what you should do. It tells the anesthesiology people what they do. It tells the monitoring people what they do. And it tells me as the surgeon for what I need to do. Does that make sense? So just make sure you take a look at that. And if you do any sort of monitored cases, we have this in our room posted on the wall. And we have extra copies of it in a folder. So if we ever need it, the nurse can actually fill it out with just that one page. Okay? So that really is something that can improve documentation as well. For infection prevention, we've done a lot of things to help prevent infections. One of the things you probably aren't aware of is the need for things we do preoperatively for the patients. For example, improving nutrition, weight loss for overweight people, and diabetic management, so we can decrease the risk pre-op. But then things like laminar flow rooms, room traffic, double chloroprep. This is something else I want you to write down. There's a little, in addition to putting on the chloroprep, there's something else you can take a look at, especially if your surgeons are doing higher risk things. It's called InteguSeal, and it's from Kimberly Clark. I have no connection with them business-wise, but it's a skin sealant. And what you do is you paint it on after you're done with your chloroprep. It almost feels like Dermabond. It feels kind of like crazy glue, but it's really sticky. So when you go, then you put the sticky drape on. That sticky drape is not coming off. So it's really helpful. It provides an extra barrier for bacteria, but also makes your sticky drape stick a lot better. So you might think about using that. Repeat antibiotics. You know, we do that now about every 2 hours. And then tissue care and protection. Make sure it's moist and that the tissue is well protected, especially putting the screws in. Reticulous hemostasis. For spine surgery, we also now do this thing called vancomycin powder, where we sprinkle in some powder at the end of surgery. That's pretty much become a standard around, except for maybe like small laminectomies. And then for more actual infections, there's something called Stimulan, which are some antibiotic beads that can actually elute antibiotics over several weeks. The importance of getting a watertight closure and also using things like Dermabond. I like to do a plastic surgery closure with a subcuticular and then put the Dermabond over it, make sure you get a good waterproof seal. And the last thing that I did not put in there, patient education. Make sure you teach the patient and the family about proper wound care, including making sure they call you if they get any wound drainage, okay, so that you can intervene early. So really, most of what I want to spend my time on was focusing on things that are more generic for the OR no matter what you do. But now what I'm going to do is just spend a little bit of time in the last 10 minutes or so and just talk a little bit more about spine and spine surgery, just to give you an overview. Because last year, when I gave this talk, I spent a lot more time drilling into how we do the surgeries. But this year, I really want to focus more on the quality and the quality control. But for those of you who weren't here last year, we'll do a little bit of overview of scoliosis. So scoliosis surgery has come a long, long, long way in the last 50 years. Monday, I fly to Minneapolis for the 50th anniversary of the Scoliosis Research Society. And so SRS has been around for a long time. So before SRS, when they did scoliosis surgery, it was only for children, and the kids would probably be in the hospital for a year. They would put them in traction, like a medieval device, stretching these kids out. And mom and dad couldn't even stay with them. I take care of some of these patients that are now in their 70s and 80s. Then they put them in a body cast. They strap them in the body cast, and they mold them. And then after a while, they cut a hole out of the cast, and then they would open them up in the back and put in some bone graft, no hardware, close them up, keep them in the hospital for a few more months in a body cast, and then maybe in 2 years they go back to school. So that's where we were in 1965. Now, that's not like 5,000 years ago. That's like, that's a lot, okay? So when Harrington came out with the Harrington rod, that thing was revolutionary. It was very simple, just 2 hooks, right? And so, but at least the kids didn't, they still didn't do a body cast, but they were not in the hospital for a year. But some of those hooks would pop out, and so they would still only do it for kids. But then things just got better and better with Luque, and then multiple hooks, and then screws, and hooks combined, now screws only. So now, especially if you've been an OR nurse for a long time, depending on where you got trained, you may be still thinking back in this area where they thought that you could only do scoliosis surgery for kids. Well, now we can do it in kids and adults and even great-grandmas. But the other thing that's changed dramatically is now that the surgery's gotten much better, we can actually get the surgery done much quicker, like in 2 or 3 hours for an adolescent scoli. But also we can allow the kids to return to sports much more quickly, which before they'd be out of sports for a year. So this x-ray over here on the right shows an x-ray of a 15-year-old that 10 years ago was just below an Olympic swimmer. And she'd been told by another surgeon somewhere else that was planning to do a hook and screw construct that she would have to stop swimming for a year. Now if you're just below Olympic swimmer, okay, and you stop swimming for a year, are you going to get into the Olympics? No. You're probably not. You're probably not going to make the high school team, okay? And so this gal came to me, and I'd just come back from an SRS meeting where I was talking to some other surgeons saying the rule that we were trained with when we were residents and fellows was take them out of sports for a year. But that's when we were using hooks, where the hooks could pop out. Well, the screws are much stronger, and so I was talking to some of my colleagues saying, you know, maybe we should think about allowing these kids to go back. Because the engineer in me said, look, these are very strong. If it was my child, I would want them to go back. So I talked to this family and said, look, you know, I just came back. There's no way I can prove it for sure, but I think that this is going to, that this should hold together. So she had her surgery done. 2 weeks later, when her incision was healed, she went to the pool, put on her bathing suit. Her hump is gone, so that's nice. She gets up on the diving platform. She dives into the pool, 2 weeks post-op, and swims 4 laps. Within a few weeks, she's back competing. So we actually allow all of our scoliosis patients, as long as they have good bone quality, the teenagers and the kids, to actually go back to their sports, which is, you could have never thought of that, you know, 20 or 30 years ago. So the deformity types, scoliosis, kyphosis, spondylolisthesis are the 3 types. Why does it matter? Well, scoliosis, you know, obviously if you let it get really big, it can potentially, you know, crush the heart and lungs. But the bigger issue is more disability, problems with lower back pain, accelerated degeneration, and so on. But the key thing with this is you've got to think lifelong. You can't just think about this as a pediatric disease. You're trying to intervene early to prevent them from being disabled and have pain later in life. Okay? So that's kind of the big concept of that. Emphasis on preventing suffering. So there are multiple causes for scoliosis. It can be caused by idiopathic disease. We don't know what it's caused by. Obviously, cerebral palsy, neurologic diseases, muscular diseases can cause it. And we do know that the genetics behind idiopathic scoliosis is very complex. And so there isn't really a great genetic test for it. We used to do some mouth swabs and try to test 300 different genes, but it really wasn't that helpful. So I don't recommend doing that. On physical exam, if you're looking at patients, they may have a rib hump like this, a kyphotic hump or a rib hump. They may have a trunk shift, as you see there, and they may have asymmetric shoulders. So most of you are not doing the outpatient diagnosis. If you do have kids with scoliosis, or they might have scoliosis, we do recommend scoliosis screening. And this is a scoliometer, which is a tilt gauge that actually helps us to be more objective in measuring the hump. If this scoliometer reading is over 5 degrees, then typically we'll get an x-ray and then follow them every 6 months or so if there's a curve. So in terms of follow-up for adults, one of the biggest mistakes you can make with scoliosis, and this happens all the time, is we think of it as this. If the kid is done growing, then you don't have to worry about scoliosis anymore, right? So it shouldn't progress. Is that true? Yeah. No, because once they're crooked, if we look at the spine model, once they're crooked, let's say they had even just a 30-degree curve here, then the lumbar spine has to compensate, right? And so because they're a little bit out of alignment above, it puts abnormal loads on the low back, okay? And when we explain this to patients, what we say is, each of these discs is like a Goodyear tire, right? So you know if your car is just a little bit out of alignment, right? You're not going to get 80,000 miles on your Goodyear, right? You might get 10. Well, so if in a patient, a pediatric patient, they've actually done studies that show that if you MRI kids that have scoliosis, you can actually see evidence that it's doing some early damage to the discs, even as a teenager. And in the study that was presented last year at SRS, they actually realigned a group of these kids, did MRIs before and after. And when they MRI'd the kids after, guess what happened to the discs? they actually improved. Now, is that important as a teenager? Yes. But how much longer does that spine have to last that child? 80 years, okay? Now, as a child, do you guys have an option of going out and buying another set of good years for your back? I would like one. I need at least one. No, we have to do things to prevent that from wearing out. So that's the big preventive aspect. So if we fix it as a teenager or as a young adult, we can prevent them from needing a much bigger surgery later in life and prevent a lot of disabilities. So there's a good picture of that right here. This is a gentleman that I saw from Mississippi who had about a 40-degree curve when he was a teenager, but you can't see it too well from where you are, but all of his lumbar discs are worn out. If he had this fixed earlier, he would have a surgery this big. Now guess how big a surgery he needs? Right? And so would you rather have a surgery this big as a 16-year-old or a surgery this big when you're 53 years old and you got a full-time job? Okay? So that's the benefit of that. So just in the adolescent, we get very nice corrections, and that helps with preventing pain later in life. This just shows another example of an adult patient. Look at how much we have to put in. You know, we have to go all the way down to the pelvis in some cases, and it's a lot bigger surgery. And they end up developing a lot of nerve problems, spinal stenosis and so on, because of that arthritis growing into their spine. So just a quick case presentation. This is just a Harrington rod patient that we saw that you can see is pitched forward. And this is just a good example of flat back syndrome. So before we knew what we know now, they used to put the rods in fairly long, and they put them in very straight. Okay? And what that did is it took out the lumbar lordosis. So some of these patients then develop severe collapse below their fusion, and now sometimes need to be revised like this, where we can actually put a spacer in the front and actually help them to stand up straight again. But now we don't see as much of that, because now we're smarter about doing the initial surgery where we contour the rods better. So kyphosis, very briefly, is a forward bent posture. That can cause pain not just over the hump, but it can also cause pain in the neck and the low back that we're trying to compensate. It can actually be post-surgical as well, which we call proximal junctional kyphosis. And that can occur in teenagers or in adults, either from trauma or from osteoporosis. For spondylolisthesis, spondylolisthesis is a slippage in the spine. And in children, when we see spondylolisthesis, it usually is coming from a stress fracture. You can see right there's a fracture. That's called a spondylolysis. If that piece breaks, the pars, then the L5 vertebra can actually start sliding forward on the S1 vertebra. And so we can treat it conservatively in a brace, but if that doesn't work and it continues to slide, then sometimes we actually have to fix that. Sometimes that becomes symptomatic in adult patients with nerve pinching, especially going down the L5 nerve root. So this is just an example of a boy we saw who needed revision surgery, and you can see here he had surgery done somewhere else. His L5 vertebra is literally like just teetering on going off the front. And if you see how he's standing, he has to stand really funny. So we literally had to take Humpty Dumpty and put that vertebra back on top, and now he can stand up straight again, and he's feeling a lot better. The last thing I'm going to review in terms of the spine stuff before I close and do my conclusion is make sure you make a note of these 5 red flag signs. You should write these down, okay? So, because you guys are nurses, and if somebody's going to call you up, a neighbor, and they have a back problem, so the key thing you need to know as a nurse is when are you sitting on an emergency, right? Because you always feel bad if you give your neighbor advice or a family member and it turns out that, it was worse than you thought. So there's something called the red flag signs. And these are all signs that we call cauda-equina syndrome, or the other term for it in the spinal cord is called acute myelopathy. So you should memorize these. It starts with loss of bowel and bladder control. Now, almost everybody over the age of 50 has some sort of bladder or something or other, a little emergency. We're talking about you're peeing on yourself and you don't know it, or you're pooping on yourself and you don't know it. All the other 4 start with the word progressive, and it's weakness, clumsiness, numbness, or increasing radicular pain. And that could be going down the arm or down the leg, okay? The key word here is progressive. If somebody has some sciatica in their leg and it's just staying there, that is usually not a surgical emergency. If they're peeing on themselves, or the numbness keeps creeping up their leg, or their legs are getting more clumsy, then do not pass go, Do not collect $50. Call the ambulance, get your butt into the ER because you may have Claude Aquinas syndrome. Because if you do have acute Claude Aquinas syndrome, if you don't get the pressure off within 24 or 48 hours, then you may not get that neurologic function back, okay? So just remember your red flag signs. So in wrapping up, the Scoliosis Research Society, we talked a little bit about that already. We talked a little bit about playing sports. I'm just going to close with one case that we just did here at WakeMed last year. This is a boy that had surgery done somewhere else, had several infections. He has about 130 degrees scoliosis, and he's 10 years old. And the scoliosis is so bad that he can't eat. And so we tried to improve his nutrition over a year or so. But if you see here, you can see why he's having trouble eating, right? Because his whole abdomen is being squished. And so what we had to do for him was actually admit him here at WakeMed. And you can see his x-ray looks pretty crazy. CT scan. So what we did is we admitted him last year, actually just right after I gave this talk last year. We put him in traction and started to feed him. He gained like an immense amount of weight over about a 4 to 6 week process. He was here for Halloween. He was actually in the News and Observer with the NC State football team. And he actually did pretty well in traction. He's smoking and joking with his dad and his brother. And here he is walking on this cart that we built for him. And he actually skateboarded on this cart. He's the first boy on the planet Earth who's actually ever skateboarded in skeletal traction. And then in December last year, we actually took him into surgery and got him straightened up. And so if you look at this, you can actually see how he changed. So you can see how his nutrition got better. This is just some traction, but now look at how nice and straight his back is. He's a year out now, and he's doing great. So that's a great example of teamwork, working with nutritionists, nurses, physical therapists, occupational therapists, traction, neuromonitoring. Think about how many people really helped this boy, Jonathan, to not just have a quality of life, but to have life, okay? And our OR nurses here at WakeMed did a great job. We had everything, including the kitchen sink out for this kid, including a special wad system if his bone quality was not going to be good enough. At the end of the day, we had this huge party for him where everybody got together. Even the CEO of the hospital came in and said hello. So at the end of the day, you know, scoliosis is a lifelong disease. Think about it that way. And in conclusion, you know, I guess the key thing is that think about compassion, humility, and learning. And for learning, we always remember my old Jacqueline's husband's name, Eli. And so if you think that you see an error, instead of calling it an error, say, I think I got an Eli. Okay? And so it sounds a lot better than error, doesn't it? Because the whole point of E is that E leads to L, and L leads to and I leads to improvement, which means your job is less frustrating, right? And so this really has changed the way my office runs and how we run the OR, because people actually like to be in my operating room. Right, Julie? Yes. Because people, and now, like, there's a lot of new surgeons coming into Duke Raleigh and so on, and it's like the nurses are kind of flocking to safe zones. So, you know, as a surgeon, I like to have good staff, so it's better for me to practice this way, but it's also better for you. Thank you very much.